Okay, I think we'll make a start. So good morning everybody, and welcome to the Practice Reflection Learning event of injuries in non-mobile babies and children. My name's Kellyanne Perry. I'm the Practice Improvement Lead for Walsall Safeguarding Partnership, and today I'm joined with 4 of the presenters who are going to take us through the learning event today. So today I'm joined by Sophie Reed-Willits, who's the designated nurse for safeguarding children at Walsall CCG, Lisa Robinson, who is the lead nurse for safeguarding children, Walsall Healthcare Trust, Dr. Shiv Rajdev, who's the named doctor for safeguarding consultant community paediatrician at Walsall Manor Hospital, and Claire Jervis, who is the team manager at the Multi-Agency Safeguarding Hub, also known as MASH. We are recording today's session because there's lots of people that couldn't join the event because it was fully booked. So we are looking at being able to send out this at a later date to people, the recording of this. So thanks, so just be aware that we are recording. Let's just move on. We do ask that you all keep your cameras off today because there are currently 84 of us in this meeting. So just to make sure that everybody doesn't get kicked out, if we can just make sure that we keep cameras off, and if you can put your microphones on mute just so there isn't any feedback, if that's okay. For those of you who aren't aware of Teams, you can find your camera function and your mute button at the top, and also there is a chat function as well. If whilst you're listening to the presentation you do have any questions, we are going to do a Q&A session at the very end. So if you'd like to post your questions in there, if they're kind of questions that we can answer as we go along, then we will post in the chat function and answer those, but then we'll keep some of them in. If we have time at the end, we will go through that Q&A and answer some of those questions for you. If we do run out of time, what we said we will do is we'll collate those questions and we will get that sent out to you at a later date. So we will send out the PowerPoint presentation to you afterwards as well, along with the recording of this. And one of the things that we do ask is that, if you can, if you've got other colleagues that weren't able to attend today, if you want to use the recording to be able to share within team meetings, that's absolutely fine. It's just about getting these key messages out to all professionals. Okay, so I'm going to hand you over now to Sophie Reed-Willits, who is going to continue with today's presentation. Over to you, Sophie.
Hi everyone, thank you, Kellyanne. So I'm Sophie Reed-Willits, designated nurse for safeguarding children at Walsall CCG. The purpose of today's session was following on from a recommendation from a rapid review that we've recently had in Walsall. So for those of you that aren't familiar with the term rapid review, the purpose of a rapid review is to assemble the facts of a case as quickly as possible in order to establish whether there are any immediate action that's needed to ensure a child's safety, and also look if there's a potential for a national or a local child safeguarding practice review. So in this case, the Safeguarding Partnership decided that it did not meet the criteria for a CSPR. However, there was significant learning identified, which links to the aims of today's session, which, as you can see from the slide, are to increase awareness and understanding of bruising in non-mobile babies, including the interpretation of medical opinion, and to gain an overview of the Regional Child Protection Procedures, which has recently been published. So moving on to the objectives, we hope that by the end of the session today you'll feel confident and able to explain why bruising in children who are not independently mobile in any location is a concern, and explain what to do if a non-mobile child presents with bruising, looking at local procedures in Walsall. And we're fortunate today to have Claire Jervis, who's the MASH manager, who's going to go through this in more detail. So I'm going to hand you over now to Lisa Robinson, lead nurse from Walsall Healthcare Trust. So Lisa referred this case into the Safeguarding Partnership earlier this year. So she's just going to give you a brief overview of the case.
Good morning, everybody. Thank you, Sophie, for my introduction. So I will provide a brief overview of the case. So at 4 weeks old in June 2020, AS was presented at Walsall Manor Hospital via ambulance because of an unresponsive episode. During the examination, bruising was evident across the body, and also there was petechial bruising, which has small red and purple spots on the skin, and our consultant Shiv will go into more detail about bruising later on in this presentation. But the petechial bruising was noted on the left side of her neck and face, and these bruises were judged to be likely non-accidental. A CT scan of head, skeletal survey and an ophthalmology review was undertaken and did not identify any abnormalities. Police were informed and an uniformed officer attended the hospital and then visited the family's home address. They checked AS's older preschool sibling, and during a safe and well visit, they observed no marks or concerns with the older sibling. The parents gave a consistent account of AS's injuries. As there was no concerns found and AS injuries were deemed to be unexplained, no immediate action was taken by the police. The child protection medical was reviewed by our colleagues at the Birmingham Children's Hospital for a second opinion, and that's as per protocol. And a strategy discussion was held. And a single agency, Section 47, was initiated and a social worker was allocated. Prior to AS's discharge from hospital, a second strategy discussion was held and both AS and her sibling were discussed. Upon discharge, social workers visited the home daily and completed a single agency Section 47 assessment. The case was closed the day after the second skeletal survey. A month had passed and AS was 8 weeks old, and she presented at Middlesex Hospital with a displaced fractured femur. No explanation was provided by parents who had been staying at a family member's home. During the admission to Middlesex Hospital, the doctor conducted another skeletal survey. The survey found the complex fracture to the right femur and also possible healing fractures to her left sixth rib. So it was the sixth rib on the left side. As Sophie explained, it was a very complex case, but also as well as looking at the case during the rapid review meeting, we identified as a partnership that there was some good practice as well. The learning review identified, firstly, when it came to good practice, that there was swift paediatric assessment of AS when she was first admitted to Walsall Manor Hospital. That assessment took place out of hours and, as I said, was undertaken very swiftly by the paediatric consultant. There was also good practice identified with the police. They also did an out-of-hours response very swiftly. They went to the home and undertook a safe and well visit to check on AS's older sibling and found that there were no concerns identified and there was no bruising. There were some reflections about how can we support and improve practice as well as looking at good practice. The reflections included that the systems outside WHT, that's Walsall Healthcare Trust, did not seem to recognise that the medical view was that AS at age 4 weeks was a victim of abuse. The petechial bruising on the neck was likely to be non-accidental, but accidental cause could not be ruled out. Yeah. If I could have the next slide, please, that would be great.
All right, sure.
So Shiv will go into more detail about the bruising, different types of bruises, and also about non-accidental and accidental bruising as well. The learning also looked at the interpretations of medical opinion on bruising and injuries across agencies and said it was definitely a learning that we needed to undertake, hence the session today. That was an over-optimistic view became dominant when the medical opinion described the cause of the bruising as unexplained. This means no plausible explanation had been provided to explain or give an account for the injuries, which made non-accidental injury a much greater likelihood. Just to summarise, there was an optimistic view that although the bruising was unexplained, we was more optimistic, some of our aid partners, around the cause of the injuries to AS. The dominant view appeared influenced by the view of the uniformed officer who had visited the family at the home address that night AS was taken into hospital. As a partnership and the professionals, we did not challenge or explore that further and consider that she was 4 weeks old and the nature of the bruising, and also what our medical team had said. So we should have really looked at that, challenged that and explored more. The strategy meeting appeared to have been guided by this view, and this further enabled how professionals understood the medical opinion and terminology. So although our doctors, we knew in terms of the bruising and what that indicated, it wasn't widely shared in terms of the knowledge and understanding from our non-medical colleagues, coupled with the fact of we didn't explore the opinions from the uniformed officer. It was felt that the agencies could have explored further where the bruising on the neck came from. We could have looked at the regional guidelines on bruising in non-mobile babies. When a petechial bruise cannot be explained, it is most likely to be non-accidental. The review identified that professionals were not aware that petechial bruising indicates the injuries are more likely to be non-accidental. And I'll now hand you over to Sophie, who will explain the regional child protection procedures for West Midlands injuries in babies and children under 2 years of age. Thank you.
Thanks, Lisa. So before Dr. Rajdev goes on to do his presentation, I was just going to give you a brief overview of the regional guidance that's just been published. And as you can see, the link to the guidance is on the slide and can be sent out after today's session. So the aim of this guidance is to support practitioners by providing information about the management and referral of babies and children under the age of 2, particularly those who aren't yet independently mobile who've presented with an injury. So it's important to note that this regional guidance doesn't replace the process that needs to be followed once a referral to Children's Services has been made. And again, we will be making sure that you understand the local referral process in Walsall by the end of today's session. So children under the age of 2 are at an increased risk of serious physical abuse, and they are rarely able to communicate the history themselves. So non-inflicted injuries in non-mobile infants are unusual. And we also know that children with a disability who are not able to move independently are also at risk of serious physical abuse. So it's important to note that even small injuries may be significant and may be a sign that there is another injury that's not visible, e.g. a fracture in an infant with a small bruise. So it's important that as frontline practitioners and as managers of services and everyone here today, that you use the guidance to support you and to support your team in understanding the management of children under 2 who present with an injury. So please share this guidance, among your teams, among colleagues, and Kellyanne will also be ensuring that it's accessible on the Walsall Safeguarding Partnership website as well. Okay, so I'm now going to hand you over to Dr. Shiv Rajdev, who's going to go through bruising in more detail.
Yes, very good morning to all of you, and thanks to all for joining us today. So I'm Dr. Rajdev, named doctor for safeguarding and consultant community pediatrician. Yeah, next slide, please. So what can go wrong? And, so we've seen that sometimes there's failure to recognize signs and symptoms of abuse. Sometimes there's failure to follow child protection policies and procedures. A very common theme comes across is that there's failure to communicate concerns with other people, and also failure to confront, challenge, or think outside the box. I'll ask this question again, and where all things can go wrong at the end of my talk. Next slide, please. I think amongst the slides, I think this is the most important slide. And we all hold pieces of the puzzle when we deal with child protection cases. And I really want to emphasize is that the health, social care, and police are equal partners. Next slide, please. So when a referral comes from social care, a pediatric assessment is involved. And what does a pediatric child protection assessment involve? And it's an important component of the child protection investigation. I feel that one of the most important aspects is the history. We also will do a talk-to examination, a detailed documentation in the child protection performer, including line diagrams, photo documentation. And additionally, the assessment includes any relevant investigations and writing a report with an opinion. So this is, in a gist, a thorough assessment for child protection assessment. And so what in the history will make you suspicious of physical abuse? And sorry, can't be interactive because of the limitations of COVID, and you have to do online. And essentially a significant injury where there is no explanation, and an explanation that does not fit the pattern of injury, an explanation that does not fit with the motor development stage of the child. For example, you find a bruise in a baby and mom says the child has rolled over. Injuries in infants who are not yet independently mobile, an explanation that varies when described by the same or different carers, multiple explanations that are proposed that do not explain the injury sustained, delay in presentation, or an inappropriate response, especially if a parent or carer is not concerned about a child's injury at all, or is being very, very aggressive. And sometimes a carer may say about a child's inappropriate response. For example, you might question, the child has got an injury. Weren't you aware of that? And mom might say, oh, child didn't cry, didn't feel any pain. You should be suspicious. Presence of multiple injuries is concerning. Child or family known to social care already. Previous history of unusual illnesses, injuries, and repeat attendances. Yes. So bruising in a child who is not independently mobile in any location is a concern. We should not be seeing the bruise. Yeah. And unless there's a very valid explanation. A small percentage of bruising in non-independently mobile babies and children will have an innocent explanation. For example, medical causes, child is having bleeding, clotting disorders, and so you can have a innocent explanation, or it's been a genuine accident, it's been witnessed, we know that it is an accidental explanation. Next slide, please. So what are the red flags? So if you see multiple or clustered or pattern bruising, it raises concerns. Pattern bruising could be just an imprint of an hot iron. Imprinting, yeah, it could be an imprint of a hand mark, or it could be the imprint of a hair straightener. Yeah. Petechia, and so these are small red or purple spots usually caused by minor bleed. Clinical judgment regarding all unusual markings where the referrer is not confident about origin, cause, explanation. So if got any concerns, yeah, flag them up. And children with physical disabilities which impairs their ability to mobilize or to speak at all. Next slide, please. What do you mean by not independently mobile? It's child of any age who is not yet crawling, bottom shuffling, pulling to stand, rolling over, cruising, or walking independently. The West Midlands guidance applies to all babies under the age of 6 months. Next slide, please. Let's talk about injuries, bruises, bites. We are focusing on bruises. Next slide. So what is a bruise? It is caused due to a blunt force trauma where the top layer of the skin is unharmed, but the underlying layer of the skin is damaged, causing rupture of small blood vessels with blood leaking into the surrounding tissues. The bruise margins can blur and blood can track and may not represent the shape of the causative object. For example, if there's been a big bruise over the scalp area, the blood might trickle down through forehead and you might see a swelling on the eyelid. This can be seen in extreme cases. Next slide, please. What is a petechia? Yeah, these are pinpoint bruises caused by shearing forces or suction. And shearing forces are forces acting in opposite directions. These are very suggestive of non-accidental injuries if there's no explanation. Next slide, please. Sites not to be missed. Don't miss the mouth, the genital area, around the buttocks, behind the ears, and the soles of the feet. Next slide, please. A common question comes to us, to the medical team. How old is the bruise? Next slide. Next slide, please. Yeah. Unfortunately, a bruise cannot be aged accurately from clinical assessment or from a photograph. At this point, the practice of estimating the age of a bruise from its color has no scientific basis and should be avoided in child protection proceedings. Terms such as fresh or old bruising should be avoided. Next slide, please. And sorry, it can't be interactive, but if people can comment, what do they see? Yeah. I'll give you a hint. I'm giving you a hint there.
It's a bite mark.
Yes, excellent. Yeah. Yeah, excellent. Yeah. So people are awake. Yeah, thank you. And next slide, please. Yeah. So human bites are always inflicted injuries. They're currently the only physical abusive injury where there's potential to identify the perpetrator. This may be from dental characteristics or salivary DNA, that is salivary genetics, and therefore it is important to recognize a potential bite. Refer to a forensic odontologist, that is a dentist experiencing in the forensics of dentistry where available. And many human bites are not recognized as such and are dismissed as bruises. The important thing is any bruise with the shape of opposing curves should be treated as suspicious. Next slide, please. What do you see here? Yeah, people can comment. Yeah. I'm waiting for comments. What do they say? Oh, excellent. You are a star. Hannah Osborne, you are a star. Yes. You hit the jackpot. Yes, yes. Oh, lovely to see those comments. Lovely. Yeah, thank you. Yes. Next slide, please. Yeah. So, uh, you see Mongolian blue spots. These, yeah, you can see at the around the buttocks, the lower back, and you can see also on the arms. Yeah. Yeah. Next slide, please. Yeah. So these are flat bluish to bluish gray, blue black, or even deep brown skin markings. They commonly appear at birth, but they can also be seen after birth. Yeah. And in fact, they can be seen anywhere, but the common sites are the base of the spine, buttocks, back. Then they usually disappear 3 to 5 years after birth, but they can be seen in adult life, very small percentage. Somebody, can we include images on? Uh, yes, I would have loved to. You've asked a very relevant question. Can we include images on from other ethnic, not the same, to see in darker skin? Where, Natasha, you've asked a very nice question. Yeah, I fully agree with you. Yeah. So on that note, and can I ask, is it that if people can comment in what percentages of cases can Mongolian blue spots be seen in Asian children? Yeah. I'm trying to make it interactive. Yeah.
About 70%.
Yeah, quite close. Yeah, you can go a bit more up. Yeah.
75 to 80.
Okay. 85 to 100%. Yeah.
Wow.
So that's, yeah, I'm claiming a few studies. Yeah. And that's yeah, it's very relevant question. Some people have asked me. Yeah. So that is Mongolian blue spots the same as birthmarks? Yeah. A difficult question, but I would, something which is present since birth. Yeah, I think that's a birthmark. Yeah. So, and yeah, so that would be my answer. Yeah. And Nick, another question. And in what percentages of black neonates would you see a Mongolian blue spots? So in what percentage of black neonates will you see Mongolian blue spots? Yeah, quite close. Yeah, very close. Very nice. Yeah. So yeah.
60%.
Yes, yes, yeah. 60%. Yeah, greater than 60%. And how much in Hispanic neonates? In how much percentages? Yeah. I'm getting very nice responses. Very close. Yeah. Yeah. In
20?
Hispanics. Hispanics. Yeah. A bit more. Yeah. 46 to 70%. Yeah. And white neonates? Yeah, people less than 10%. Yeah. Yeah, next slide, please. Yeah. Yeah. So these are sometimes mistaken for a bruise. Yeah. And this can result in unfounded concerns about abuse. For this reason, it is important to have a diagnosis confirmed by a doctor and the diagnosis documented in the child's record. So it's very important that when a baby check is done, this is recorded so that it doesn't raise unnecessary concerns later on. Next slide. Yeah. So birthmarks, somebody had asked this question. Would you say it was Mongolian blue spots a birthmark? I would say something present from birth is a birthmark. Yeah, yeah. So I would say yes. Yeah, correct me if I'm wrong. And birthmarks, other birthmarks which are common. Yes, yeah, it can appear later after birth. Yes, I agree. Yeah. Some parents ask if it goes away. Yes, it goes away by 3 to 5 years. Yes, yeah, and yeah. Yes, in small percentages, it can yeah, it lasts lifelong. Yes, that's Venice's answer. Yeah, my answer to Venice. Yeah. Yeah. Salmon patch. Yeah, and these are usually present. This is birthmarks present on the forehead and at the back of the head. You can see strawberry mark. Yeah, this is a mark which is raised above the surface of the skin, and this usually go away by around 7 to 8 years of age.
Is that an hemangioma?
Yes, yeah, it's strawberry hemangioma. That is, yeah. And when they do fade away and they will become less in color, small in size, gradually they will go away. Next slide, please. I think what is crucial is at use. Okay, somebody's put up a question, Satpal. I think what is crucial is at use, say once established, we record in a system so families are not cause unnecessary trauma. So is this Satpal you're asking about uh, the are you talking about Mongolian blue spots, I gather?
What I'm saying,
Should
Doctor,
we
is that once we've established it, if we're working with a family and we know that they've got a mark which is not a bruise, which is not suspicious, then
Yeah.
if we've marked it on our systems,
Yeah.
and if I left, then it's obvious when somebody else works with that family that it's not something to put the family through another trauma.
Yes, yes,
Yeah.
yes. I think that's sharing of information and good
Absolutely.
record keeping. Yeah, exactly. That's what wanted to mention. Thank you. Yeah.
Excellent.
Yeah. What happens following referral from social care? So we at Walsall Healthcare NHS Trust, we have got a child protection medical standard operating procedure, and we also have got a child physical abuse referral pathway. So we have in the routine days of the week, 9 a.m. to 5 p.m. every day, a community pediatrician who has got designated time for doing child protection medical assessments, and we've got clinic slots at 2 o'clock, 3:15, and 4:30 p.m. So if need be, we can do 15 child protection medicals, and if need be. And at weekends and out of hours, and child protection medical assessments are done by the on-call pediatrician, and they may supervise a middle grade doctor. Next slide, please. Yeah. So what investigations are essential in a non-mobile infant or child? And we've got national guidance. Yeah. So I will try to simplify my talk. And so infant or a baby might have a genuine cause for having a bruise. For example, if they've got a bleeding and clotting disorder. So we have to send for investigations to rule out a bleeding and clotting problems. Sometimes the first line investigations, they might reveal some abnormality. Then we have to send for a second line investigations, which may take more than usual amount of time. So normally we would get results within 10 days of our first line investigations, but sometimes it take much longer. Some of the basic results we get within 24 hours of time. Other important investigations we have to do is to do a skeletal survey. So essentially this is a whole body x-ray, and this is quite a process which there's national guidance from the Royal College of Radiology. 2 trained radiographers have to be available, and we need some dedicated time, and it's time consuming. So what might happen is that suppose a child is admitted on a Friday, and we have to get a whole body x-ray. So It may happen after the weekend when sufficient number of personnel are available. Child may be moving, so it may require sedation. And once we have done the skeletal survey, the guidance has to be done within 72 hours following a request. It has to be reported, and it has to be reported by 2 trained pediatric radiologists. Yeah. And so the reporting might take some time. Yeah. And so in all this while, the patient might be admitted to the ward. And following this, and the initial skeletal survey may be reported as completely normal, which is the whole body X-ray. And the guidance is that you have to repeat the skeletal survey of the long. So this is a more limited X-ray, which is X-rays of the long bones in 11 to 14 days time. The reason of repeating the X-rays in 11 to 14 days time is that after an injury to any bone, the fracture or injury might not show up in the initial skeletal survey. A CT scan head is also required in any infant or baby where there is suspicion of physical abuse. The reason being is that they might be bleeding within the brain. Yeah. As you can see, if there's a bruise, you have to rule out there may be a shaken baby along with it. So they may be bleeding within the brain. And that's the reason a CT scan head is required. If the CT scan head shows an abnormality, recommendation is to do a MRI head scan if needed. Yeah. So that will take more time to come at a conclusion as to what sort of injuries the infant or baby has. An ophthalmology examination needs to be done within 24 hours. Yeah. So for my social care colleagues, can I ask you why would we do an eye examination? So this is to find out if there's bleeding in the back of the eye, which is called retinal hemorrhages. And yes, yeah, thank you. Yeah, excellent responses. Yeah, and this is suggestive of injury to the brain. So you can see that this is the investigations are time consuming, and these have to be reported by trained radiologists, and the reporting can also take its own time. Yeah. So I I'm going to use this opportunity to um, uh, let my social care colleagues realize as to we try our best to have the investigations, their results as soon as possible, but we may not always be able to get very quickly, yeah, for obvious reasons. Yeah. And next slide, please. Yeah. So I will. What do my colleagues think as to if a child has come with a bruise to the body, and we have admitted the child in the hospital? We have requested for a skeletal survey, and a CT scan has shown some abnormality. We're waiting for an MRI head scan. Yeah. And we have also sent for a blood investigations. And it's nearly a week. The skeletal surveys happened. We are waiting for an opinion from the tertiary radiologist. And the social care is desperate that we want an opinion as soon as possible. The question to my colleagues is that and it's COVID time, the baby is admitted in the COVID time, where do you think is the ideal place for the child to stay? An infant who is at risk of infection, it's COVID epidemic, and we are waiting for patients. We have tried our best. They're working at the best possible pace. All my colleagues from radiology, they're trying to report at the earliest, but this is what has happened. Yeah. So what do you think? Where should the child stay? That's a question. Open, yeah. Question open to the audience.
I'd say the hospital haunted investigations are completed. You're happy that there's no risk of harm.
So, okay, yes. So Paul has given an excellent reply. Yeah. If not necessary, yes. Yes, somebody said inpatient. Yeah. It's very difficult to answer. The answer is a safe place. Although we have COVID care, although we have COVID care, is not always first option. Somebody says in hospital. Okay, yeah, yeah, and okay. So I feel is that my answer would be is it that this is where interagency, interprofessional working is very, very important. Yeah. So hospital is not a place of safety. Yeah. Baby should stay in an appropriate and safe place. Yeah. And rather than hospital, and this should be subject to interagency discussions. Yeah. Should not be delayed pending. However, an initial medical view in relation to injury is required to assess social care, informed decision. Yeah. Yeah. Child should not stay with. Okay. Yeah. Somebody's mentioned child should not stay with parents as injury likely to be. Yeah. My answer would be in any safe and appropriate place. Yeah. And subject to interagency discussions. I think the discussions between the professionals is very important. Yeah. And opinion, coming to opinion, we have done a child protection medical investigation and assessment, initial assessment, and sometimes we are able to give very categorical opinion. For example, a baby has come with one single bruise on the body, and we do a skeletal survey. We find posterior fractures. Yeah, so we'll give an easy opinion. Yeah, and findings consistent with inflicted injury. Yeah. And sometimes we may not be able to give a very definite opinion, but we will say that some sort of injury, either non-inflicted or inflicted injury, is more likely. Yeah, and on the balance of probability, we'll give an opinion. Or we can say that findings consistent with non-inflicted injury. But sometimes is it findings we start in investigations and findings are indeterminate, and we have to await the results of further information, further investigation. It has also happened is that an injury was seen and child was not brought in time. Yeah, and when the child has been brought for examination and no injury was seen. No injury seen does not mean that harm has not happened. Yeah. So I think the history is very important. The next slide, please. Yeah. Yes. And injury as a result of lack of inadequate supervision and care. Yeah. This I've seen quite often, and I'll just narrate an incident as to how effective team working can help. Yeah. I had once seen a child, yeah, who had an injury on the palm and also an injury of the back of the fingers. Yeah. So there was injury on both sides, and normally I would have said that, oh, this is unlikely. How will child get an injury on both sides? Is it until unless an adequate explanation is given? Yeah. But on that day, I had a really wonderful social worker. What she had done, she had visited the home. She had got a photograph of the hair straightener. Yeah. And she showed me a picture. Doctor, I think the baby has touched this hair straightener, which could have been hot, and the child has touched the hair, one end of the hair straightener, and while pulling her hand out, and this might have touched it. Yeah. And I think that was a very relevant thing for the social worker to do. And I came to the opinion that that accidental injury is a possibility. So I think the presence of social worker, a history given by social worker, is very, very vital, and I can't emphasize the importance of team working and having a balanced opinion. And because uh, I think we often fail when there is not team working. Yeah. And we have also seen on occasions is that you do an initial assessment, and despite all the best efforts, despite having the best opinion, and a doctor thinks that, oh, we need to have a discussion amongst peer review. And we have got child protection safeguarding standards, and uh, peer review meetings are meetings where the opinion of the lead consultant is reviewed by other consultants. Sometimes some we've seen is that doctors have used terms like mechanism of injury unexplained. Yeah. So how would a social worker interpret if a report says that mechanism of injury unexplained? Yeah, I think Sophie and Lisa has covered already. Yeah. So yeah. So in mechanism of injury unexplained. So how would a social worker interpret? Any comments? Yeah. So what the medical, yeah. Yes, yes. What the doctor is trying to say is it, yeah, that he cannot explain how this injury could have happened. So he's saying is that non-accidental injury is a possibility. Yeah. So yes, and similarly, when a report comes in non-accidental injury cannot be ruled out, he's saying is that non-accidental injury is possible. Next slide, please. Yes. So when we give an opinion, the pediatrician should ensure that the social care are informed in regard to the outcome of the initial assessment as soon as it's completed. Yeah. So, and I think what the initial assessment has shown, we should communicate to the social worker. Yeah. But the final report will depend on the investigations, the timing of which may not be under the control of the pediatrician. Yeah. So, and sadly, the social care and the police may not always get a definite opinion for the cause of the bruise, whether it is inflicted or non-inflicted. Next slide, please. Yeah. So I have uh, picked up an article from the Social Care Institute of Excellence. I put the link, and it's quite uh, good reading. So please read this. Yeah, and so this is all learning from serious case reviews, and I've just mentioned where we can improve. So what we are seeing in Walsall is not limited to Walsall; it's happening nationally. Yeah, and I'm just reading out a few comments I read from this article, from which is from the Social Care Institute of Excellence. So this is a comment made by local safeguarding children's boards is business manager, is if pediatricians can't definitely say an injury is non-accidental, other agencies veer on the side of accidental. Another comment by a CCG member, there's almost a sigh of relief. We can't prove it, so we don't need to take action. And does it ring a bell to a similar bell here in Walsall? Yeah, just to have a few comments. No comments. Yeah. Next slide. Yeah. So yeah, there was learning from the serious case reviews. I have put the references below. Please have a look later on. Yeah. So what I want to emphasize is that concern of harm is enough to convene a strategy meeting, and you do not necessarily need a proof.
You'll be able to hear this.
You're not yet halfway through the afternoon, and you're already behind with your appointments. And it's my 2-month check, so you've asked Mum to slip off my baby grow, and you notice a small bruise on my chest. So, how are you going to deal with that? You can't ignore it.
Oh yeah, I noticed it the other morning. It wasn't there the night before. Maybe she lay on her dummy?
You're not going to accept that, are you? I can't even roll on my own yet. How am I supposed to have given myself a bruise?
It was probably George. He can be very boisterous.
Oh, the story's changing now. He can sometimes be a bit rough, but it's very unlikely he has caused the bruise. And if he had, surely Mum would know.
She's always crying for no apparent reason. It's only a little bruise.
Happy now? Come on, professional curiosity is required. Challenge her.
You're saying I've hurt my baby.
I know it's not easy, but you've got to keep me safe. It's your professional responsibility, and any reasonable carer will understand this.
It's extremely rare for immobile babies to bruise, and a bruise must never be interpreted in isolation. At the very least, any explanation needs to be clear, consistent, and plausible, and in keeping with the baby's developmental ability. There should be a clearly remembered significant event and appropriate parental response. It is very unlikely that normal activity and play will have caused bruising, including rough handling by parents or siblings. A holistic multi-agency assessment must take place to consider non-accidental injury. If you have any doubt, you must inform parents and make an immediate referral to children's social care. Bruising in itself is a serious injury in this age group. In addition, apparently well babies may have other hidden injuries, such as bleeds on the brain or broken bones. Following a referral, children's social care will arrange for a social worker to urgently meet with child and family, and they'll also arrange to have a strategy discussion with the police, on-call paediatrician, and anyone else with important information to discuss the next steps to keep the child safe, including the appropriateness and timing of a paediatric assessment. Raising the concern is never easy, and you should seek immediate advice from your line manager or organisation's safeguarding team if you need support until the social worker arrives.
Remember, babies that don't cruise rarely bruise. Thank you for keeping me safe.
Okay, my name's Claire Jervis. I'm the team manager in Walsall MASH. So for those of you that aren't familiar with the MASH, so we're a multi-agency safeguarding team in the Civic Centre, and we co-located with the Early Help Hub. So the MASH would usually see these types of contacts come into the service. So we look at contacts that meet threshold for level 4 statutory intervention. So when these types of contacts come into us, there's 2 pathways. So we have the MARF and we have telephone calls. So we have a duty social worker whose core function is to deal with child protection matters and to give advice to professionals. So non-accidental injury concerns are more likely to come in via the telephone. So we'll have a social worker on hand, and there are police presence within our MASH. So we have a detective sergeant and we have a police constable. Now, when these types of contacts come into the service, we're looking for a number of things. So we want to know what's the explanation? Is it clear? Is it consistent? And what's the mechanism that's being given by the parent or caregiver? We want to know about parental responses and interaction between parents and children. We want to know if there's any history of safeguarding concerns or any previous history of injuries. We want to know if there's been a delay in seeking medical attention. So there's lots of questions that come up in terms of when we first receive the contact. We want to know if there's any older siblings at the address, and whether there's any explanation as to whether any older siblings have harmed the new baby. Any complications during delivery, and I know that Lisa Robinson had mentioned that checks with the named nurses, there should be any documentation regarding Mongolian blue spots or birthmarks. So we would consider the information, we'd talk to the consultant, we'd ask for their opinion at that stage. And as Dr. Rajdev has already mentioned, lots of the investigations are quite time consuming, so they may not be able to give a definitive opinion at that stage. But if there's enough cause for concern, it may be that we enter a strategy arena. So we'd have an initial strategy meeting with agencies across the partnership, so those agencies that are based within the MASH, and agree a strategy on how to safeguard the subject child and also consider any siblings. Is there any questions around that process? No? Okay, Kellyanne.
Okay, thank you. Okay, so anything that you've heard today and any information, for any further information or training, then you can visit the www.walsallsp.co.uk website. On there you might also find some other useful webinars or podcasts that are available to listen to, so please access it as and when you feel that you need, or if you need any further information, and also any referral forms that go into MASH found on there as well. And we do pop up, we put on there kind of any new legislation. There's links on there to the West Midlands Safeguarding Procedures, as Sophie mentioned at the very beginning as well. So just please make use of that website and have a look through it, because there'll be lots of safeguarding information on there. We also sent out some pre-reading that was attached to this link. So the way you've accessed to get onto the call today, there was an attachment on there, and it's a leaflet around babies and bruising. So please have a look at that, print it off. It's something that you can pop up in staff rooms and things like that to make other people aware. We're on to the questions now. Now, I know that Shiv's obviously answered some as they've gone along. Claire, because of my technical issues this morning, you've been monitoring the questions. Is there anything that's come through that hasn't yet been answered, or is there anything?
Yeah, I think Dr. Rajdev was answering them as he was going along. I don't know if there are any other questions. Particularly, I know that we've had quite a lot of non-accidental injuries into the service during lockdown in particular. And there are predicted there'd be quite a lot of questions around as the contacts come into the service and what's expected. But I think Dr. Rajdev explained that it's quite a time-consuming process. Medical investigations need to take place, and we can only work on what we're given at the time. So the presenting information. I don't know whether we want to sort of open the floor, or we can't do any breakout rooms, can we, to make it a bit more interactive?
Well, we have got a breakout room function.
There aren't any questions coming up at the minute on the chat function.
And is there anybody on the call? Because like I say, this is an interactive call. Is there anything anybody would like to say? Anything anybody would like to add to anything that they've heard today?
Yes. I think it's we can learn from each other. Yeah.
Definitely. If you do, or you'd like to come into the call, if there's a hand function at the top, if you just want to raise your hand, and so that everybody's not all speaking at once. Or some feedback around the training, how people found it. Has it been useful for you? Is this something that you needed to hear? Okay, I've got Satpal Joel.
There is a question as well.
Okay,
Kellyanne.
I'm going to invite Sorry, I'm just going to invite Satpal first. And do you want to just come into the call because you've raised your hand?
I just think, Kellyanne, because we've got lots of partners that are in this training today, and it could be any one of us that could find a bruise on a child. I just think it's relevant for, to ensure that the first person that does find that shares the information precisely, relevantly, and to the point, because it does build the picture, like the video said. You've changed your account again. Should it be suspicious, then at least it's accurate. And I think, throughout of this, it has all been about partner working and sharing and doing the right thing for that child. I just wanted to clarify that from our perspective of where we stand in the profession, because we're all at different stages, aren't we?
Definitely. Do you just, Satpal, do you just want to say where you're from so that everybody's aware?
Yeah, I'm from EDT. So we were quite isolated from the daytime, but we have all the relevant services. So what you would do in the day, we do it with a lot less people in the evening, but we have to do it just as good as what you would do in the day. We need to investigate. We need to make sure it's okay for that baby. Just as that baby in that pram was saying, they can't advocate for themselves, so we're their voice. And sometimes, Doctor, I do hear we have our challenges with each other, but we all want the same outcome.
Yes, definitely. Yes, yeah. I do understand, is it, yeah, that the social care do have a very challenging role. I do recognize that, is it, and equally the medics do have a challenging role, yeah, and yeah, we need to work together despite all the challenges for the welfare of the children, and I think we've got a common goal, yeah, and yeah, as long we are challenging each other should not be seen as a criticism. Yeah, that's what I think, and we need to work as a team.
Healthy challenge, absolutely.
Yes, yeah.
Thank you, Satpal. Claire, did you say a question had come through?
Yeah, Natasha Helland. I'm not quite sure where. Natasha, do you want to? Oh, social worker. Okay. Bear with me. Okay. Hi. I do have a question for Claire. When completing a home visit with a non-mobile baby, I will ask to pick them up and play with them, such as tickling their feet and getting them to play peekaboo when age appropriate. I use this method to check for any suggestion of pain when moving their limbs. However, how would you suggest to check for pain when moving limbs and other injuries if the parent won't consent to us picking them up? Okay, it very much depends on the reason for our involvement in the first place. So I'm taking it that we're already involved, that it's an active case. So if we're involved because there's a concern around inflicted injury, or that's been a concern previously, then it'd very much depend on why the parent isn't consenting, and is that something that you'd usually do? Natasha, I don't know whether it's easier to talk to me if you're comfortable with that.
Yeah, sorry, Claire.
It's okay.
Yeah, so I'm an ASYE social worker. So when doing visits, for instance, when there's concerns around, physical abuse in babies, then picking them up and playing age appropriate games, just kind of trying to get their legs and arms moving and things. When I'm doing that, obviously, if there's pain when they're doing that, that would suggest to me as a professional that something more, there may be cause of concern there regarding more physical injuries. So I'm just thinking, even when a child is on child protection, for example, we'd still need the consent of the parents, to do certain investigations, or even to pick their baby up. They've still got PR, haven't they?
Yeah.
So I think if that was to happen, there's always that kind of gut feeling, isn't there, as a professional, that, I should have done this, I should have done that. But respecting their consent, if they say no, how do we kind of get around that to kind of check and feel that we have made those checks, even if the parents don't consent to us picking that child up? Sorry, does that question make sense?
Yeah, and yeah, it does make sense, and it's not something that you consider in isolation, is it? So you have to consider why you're involved anyway. So what was the primary concern? What's brought us to be involved? So if it is around non-accidental injuries in the previous history or physical abuse, like you've said, and if they're not consenting, yes, we do need to respect that they hold PR. So if they're telling you, no, I don't want you picking up my baby, there could be a multitude of reasons for that. Especially during these times as well, COVID times. But I'd expect if it's an under 5, so there'll be some health visitor involvement. Are they getting the same response? So is mom not taking baby to clinic, or are there outstanding immunisations, vaccinations? They're not being weighed. What's the new birth visit saying? So it's collaborating with your health colleagues as well. So anyone else that attends that property, are they concerned, or have they seen baby and baby looks as though they're not moving their limbs around comfortably? So it's a really difficult question, but like during the theme across the whole training is about we all hold a piece to the puzzle. So it isn't that we can make decisions in silo. We have to talk to each other. So I'd say in that circumstance, Natasha, talk to the health visitor, talk to the midwife doing the new birth visit. What was their opinion? Are they worried? Would mum also not consent? And are they defaulting appointments for health? It sort of builds a bigger picture, doesn't it? And then we can escalate if necessary. It's you're showing professional curiosity. It's really good that actually going out, you're doing visits, and that is at the back of your mind, and you're being quite creative, aren't you, in your response in terms of, I want to play with them, I want to play peekaboo, because you're looking for things, aren't you? So it's a really good approach, but also use your colleagues, use other agencies that you're working in partnership with, and then that will build your picture. Okay, shall we move? Okay, next question. Has the MASH team had more referrals regarding non-mobile infants during lockdown? We did initially, the first lockdown, so we started working remote on the 2nd of April. And there was quite a lot of referrals into the service from consultants around unexplained bruising, in non-mobile babies and unexplained injuries. So yes, the answer to that is yes. We did have this surge of referrals, but I think as professionals there was a heightened concern around so families that had a complex multitude of needs that would usually have access to resources and service provisions. They all halted, didn't they? So we were seeing that lots of families weren't receiving the support that they needed. And unfortunately, yes, we did see an increase, and we do still see that increase. So now our statistics for the number of contacts that are entering the service are still 1,000 plus. In excess of 1,000 contacts we're still getting, because families are in need of support now, more than ever. But we're seeing obviously voluntary agencies and support provision is halting, unfortunately. So yes, Rhonda.
Just to add to that, Claire, I know that's been the national picture as well, hasn't it? And I know via the Safeguarding Partnership, as you said, during the first lockdown particularly, in terms of referrals into the partnership for rapid reviews or learning reviews, there was 3 quite significant ones that were non-mobile babies, and they either had bruising or fractures. So just to add on that.
Yeah. Okay, right, Charlotte Taylor. Can we discuss the policy around redoing skeletal surveys after so many days due to fractures taking time to show? This was my experience previously and the advice given by a consultant. Okay, Dr. Rajdev, that might be one for you.
Yeah, and so the national guidance from the Royal College of Radiology is that the assessment, if you do one skeletal survey, you have to do the second skeletal survey of the long bones. Yeah, So investigation is not complete unless you do the second one. Yeah, if you suspect child physical abuse. Yeah? Or yeah, so that is the guidance. If you suspect, but in the process you find that, oh, this was you did a first skeletal survey, and instead of fracture, you note that, oh, the child is born with disease in which he's more prone to fractures, like fibrous dysplasia. Then in that case, if you've got a very justified reason not to repeat the second one, you can. Yeah, but the general guidance is that you have to repeat within 11 to 14 days, up to 28 days. Yeah. Does it explain? Yeah. Have I answered your question? Hello? Oh.
Yes, thank you.
Yeah.
I just couldn't remember the days, how many days it was before, in between each skeletal survey. It was kind of a set amount of days.
Yeah, so 11 to 14 days, yeah, and then up to 28 days, it's saying. Yeah.
Thank you.
Since the injury. Yeah.
Okay, next question. Hi there, Sam. I have a question about when the injury is unexplained by doctors, how would you suggest social workers make a judgment on this when medical evidence is limited? Okay, so is that, Sam, are you okay to talk?
Yeah, of course.
Okay, so when the medical opinion is coming back as inconclusive.
Yeah.
Okay, so the injury is unexplained and it remains unexplained. So we haven't reached the opinion yet that it's non-accidental, but we're saying non-accidental cannot be ruled out and it remains unexplained. So how would you suggest social workers make a judgment on this when medical evidence, it's not definitive, is it yet? Okay, so yeah, Dr. Rajdev?
We try our best. We are here to help you in the process, but whatever we are guided by objective evidence. Yeah, and so for example, is just I'll give an example. Infant comes with a bruise. Yeah, and mom says that, oh, I was trying to pick up the baby from the Moses basket, and the baby fell off from the Moses basket, and hence caused this bruise. So I'm putting this question back to you. Is it possible to have an injury cause a bruise? Yeah, if a child is being picked up and falls, yeah, from a sufficient height, yeah, to cause a bruise. Yeah.
Well, yeah, it is, but I think it's an awful lot to put on me sometimes when I have no medical training.
Yes, so it is possible, is it? Yeah. So, but and then we said that we found a bruise, is it? Yeah. This is mom's version because it's an unwitnessed, so nobody knows how it has happened. Yeah. It could be that mom has really caused this injury, or it could have happened a genuine cause for this injury. So we will do what is recommended by the national guidance. If you suspect physical abuse, you do all these investigations. If you find a posterior rib fracture, if you find a fracture, it helps. We say that, oh yes, it is consistent with non-accidental injury. Or if you do a CT scan head and MRI, we find bleeding within the brain when there should be no bleeding at all. It suggests it's a shaken baby. Yeah. So again, we'll be able to give an opinion if we find something, or retinal hemorrhage. But suppose if you're not able to find, is it that our opinion would be, is it that we have found a baby who should not be having bruise in normal circumstances. And if you look at the evidence from all the studies, is it that it's highly unlikely to find a bruise in a baby. So based on previous evidence, we will say, is it that the child should not have had a bruise. He's still got a bruise, and we can't say, is it that we'll say that non-accidental injury is a possibility, because that's what the prevalence of finding a bruise in non-accidental children for being a non-accidental cause. And we will give an opinion, is it that it is possible this might have happened, but non-accidental injury is a possibility. This is what it is. We can't give a definite opinion. Yeah. And I would put in my statement, is it that child protection evidence or the Royal College guidance, is it that the prevalence of finding a bruise in these children would be suggestive of non-accidental injury? Yeah. So I won't be able to give a definite opinion as to how it has been caused. And that's where the multidisciplinary working comes in. What's the previous history? Are the child known to social care? I think you have to make a balanced judgment, and that's the reason this is child protection is interagency working, yes, and it's multidisciplinary working. Yeah. We are here to help, but we can't always help.
And I think just to come in on that, I think that's really key, that when the medical information is inconclusive, it is then, regardless of the medical opinion, decisions on the outcome of the child protection inquiry should be, as Shiv said, multidisciplinary, multi-agency, looking at the presenting concerns, the risks, the history, etc. Because unfortunately, sometimes it is inconclusive, as Shiv's explained.
Okay, happy to move on, Sam, or any other questions?
Yeah, no, that's fine, thank you.
Okay, Joy, I raised my hand, want to verbally raise my question. Okay, do you want to come in now?
Hi, good morning, everyone. Oh.
Morning, Joy.
Yes, I think what's been said so far has been my experience in Warsaw with regards to put in the middle. You know, having children having injuries, non-accidental injuries, and the report from the hospital saying we can't rule out non-accidental injuries, a possible non-accidental injury, and all of that. And I think, as Samantha already mentioned, that leaves us in a state of you know, confusion as a social worker, I would say, because I'm the one who's to write the report for the court if we're going to initiate proceedings. I'm the one writing the section 47 inquiries, got my name on it. I'm the one who's supposed to analyze all the information from all the agencies and make it make sense for the family to understand when they read that. But then putting the onus on the social worker to make the final judgment, I would say, at the end of the day, with regards to escalating this through to child protection processes or any other processes is, I would say, really unfair. And I actually pick up from what the doctor said. We want to help, but sometimes we really can't. And that's where the difficulty we have is. I've had a case where two consultants had two different opinions. One said it was an accidental injury. The other one said it wasn't. And then they both given me this information during a section 47 inquiry. And what was I to do with this case? You know, what was I to do with that information? And the case actually did escalate to the level where the mother was making complaints about everybody, including the hospital in Birmingham, Warsaw, myself, managers, and all of that, because we couldn't just come to an agreement about what it is. So I think there needs to be a view on being clear, being definite, because that would help us to make a decision and a judgment about safeguarding the child. Giving us confusing information really can't help us as a social worker to come to a conclusion about what actions to take to safeguard the child. You know, saying it's possible, it can't be ruled out, but it is, may not be. It's not, so what decision should the social worker take in that regard? You know, that's where my worry is, and it's been the case since I've been here in Warsaw since April when it comes to accidental injuries. And I still don't find joy when it comes to cases like that. I just know it's going to come out to be possible. And then at the end, the report comes, possible, we can't rule it out. Then social worker, you deal with it. That's what I get. Thank you.
I, you know, I have attached the Social Care Institute of, I've not chosen articles from a medical journal. I've chosen an article from, I think it's an interesting read. Yeah. And what you are stating is it, yeah, I don't think this is topical to Warsaw. This is a national problem, and this is being replicated all over the country. What you are saying is it that, but at the end of the day, what I'm saying is it that people are just reliant on the medical opinion. Yeah. So, for example, if a child has been has had bruise, and if a medical person does not see a bruise at all, is it? Yeah, it does not mean that a harm has not happened. Yeah, and I can understand where you're coming from, yeah, and but you have to see the other side, that we are guided by evidence, objective evidence, and yeah, so that's what I wanted to say.
Can I just say, what I'm saying is basically, just to be blunt, yeah, what I'm saying is don't sit on the fence, be on one side, just make the decision, is it or it isn't, and then we know where we go with that. You know, at the end of the day, we get information from the school, from other agencies as well. So it's, and even the police. So it's not just we're relying and putting it all on medical to make a decision.
Yeah. Yes,
we
I
just
think,
want it to
yes,
be
I think
definite.
Yes, I think what I can understand your point, yeah, and I is it, yeah, that on the balance of probability, yeah, I think this is more probable, yeah. So that's what I have started to put on my reports, and normally that's my practice, to put on the balance of probability. I think this is more probable, but you can't rule out the other side also, yeah. It's just that you have to realize is that it's not a science, yeah, it's not a science, yeah, so you have to yeah, that's what I wanted to say. It's collaborative working, interagency working, team working, yeah.
Okay, should we move on then? Okay, so Angela, can we talk about thresholds for social care, asking parents to agree to accommodation away from home with a level of supervision, especially during COVID, when the threshold for non-accidental injury has not been established? So that's similar, Angela, isn't it, in terms of where we can't rule out non-accidental injury, but we have been given a definitive medical opinion that it is inflicted injury. So it's where we stand during that point in time, isn't it, that gap? Are you happy to talk, Angela?
Yeah, sorry, it didn't come on.
No worries.
Yeah,
so you're
that period.
You're EDT.
Yeah, I'm from EDT as well. So it's the point that we suspect, or we're waiting for further tests. Kind of the bit that the doctor picked up on, really, in terms of where's best for a child to be.
Yeah.
And I accept that's a conversation across the disciplines, but sometimes as social care, we haven't reached a threshold to say actually it is or it isn't. And so we rely on parents to agree. And if they don't agree to what we're suggesting, then do we have a threshold to take it further in terms of a court order? Because actually, hospital isn't the best place for that child to be for up to 28 days when the results are going to come back. Does that make sense?
It does. It does.
I think it was just because we've got so many colleagues from disciplines, it was helpful for them to understand.
Yeah. We sometimes get stuck. Yeah.
But equally, have we got enough legally almost to say something different? So lots of parents will say, no, you can't say my child's got an injury that I've caused. I'm going to take them home. And we get stuck there a little bit, I think.
And I think that's happened in most cases, in terms of when we haven't reached a definitive conclusion yet. So it is a difficult area, isn't it? Especially, I mean, because what will happen is as the concern enters our service, if threshold is reached to convene an initial strategy meeting, if there is a concern that non-accidental injury cannot be ruled out, more than likely we will head into a Section 47 inquiry. So we're in a child protection investigation, and if we explain to parents that this is the concern and this is what we would like to happen, and it's about what options then we have available to us. And I understand that during the daytime we may have more time than you guys working out of hours. But I think the police, I don't know whether we've got any police in the audience, but they also, it's difficult for them as well. So when we haven't been given a non-accidental injury outcome, they're very limited in what they can do as well.
Yeah.
So they can't reinforce accommodation or anything like that. I don't know if anybody can add anything to that. Okay.
That's the silence.
Yeah, can I just make a comment on that, if that's
Yeah,
okay?
yeah.
So I suppose it's just about the working relationship that we develop with parents as well as part of that investigation, and just being clear about what we're worried about. And very often we see that parents are quite open to that if there's clear explanations. So as part of the medical investigation, very often we'd have those conversations with parents that until we get clearer clarity around that, and that the assessment is ongoing, that multi-agency assessment is ongoing, that we need to ensure that there's appropriate safeguarding measures in place for the child. And that sometimes would look like additional family members may come and stay at the property, so there's additional supervision and things like that. It doesn't always mean that we're looking at the child or siblings coming out of that family home, because as you've indicated, Angela, we need evidence to be able to go to court to be able to do that if we haven't got consent from parents. So I suppose it's just about thinking outside the box really, and trying to develop that working relationship with parents, that they fully understand the concerns so that they work with us pending the investigations.
Thanks for that, Becca.
Thank you. Are there any other questions, Claire?
I think there's another question from Gemma. I'm happy to answer. Yeah.
Could we discuss the importance of medical photographs and these being obtained in the appropriate way?
Yeah, we have got, the guidance is, the standard guidance is that if you have seen photographs, if you've got injuries, they should be photographs. At Walsall and Wolverhampton, in the Walsall Healthcare NHS Trust, and it's the same team which works at Wolverhampton. We have got a medical photography team, and they are available 24/7, and they will take the clinical photographs of the injuries. Yeah. Out of hours, the arrangement is that we ring the Wolverhampton Hospital switchboard, and they will come and take the photographs out of hours. I know that recently, and it was difficult to access them, but we have investigated that. Does it answer your question, Gemma? Yeah. Hello.
Hiya. No, I think it was just important. I just wanted to raise that about medical photographs, because obviously for me, in my day job, I'm a senior prac within a safeguarding team, and then I cover EDT as a backup worker, and I do seem to attend an awful lot of CP medicals at both Walsall and at Wolverhampton, but that is the process as I know it. However, more recently I have attended for a medical and been advised by the doctor that we would use the photographs that were on Dad's phone.
No, that is inappropriate.
I know that was inappropriate. But
that's inappropriate. That is not acceptable. And I've got apologies from the concerned.
I was going to say, so I was told by the doctor at the time, but it was just so that everybody was aware, really, because had it have not been somebody like myself who was aware of that process and was aware that that wasn't actually appropriate, I do worry that perhaps somebody else may have accepted the photographs on a telephone because they were following.
No, we would have incidented that as soon as somebody would have come to know about it. We would have investigated
but then
it.
Potentially, obviously, we may have been past the point of having the photographic evidence then of the injuries. Do you know what I mean? Because the injuries may have. So it was just about being clear that actually there is a process to follow, that if it's suggested that we need medical photographs, that we need to make sure that we have the medical photographs, because there is an on-call worker who can come at any time, and to be honest, they're usually very, very quick.
So I think we have to accept that, is it? That we need to learn. And thanks for challenging, Gemma. That's what we want, to challenge, constructive, to work for the and
well, ultimately, when they leave the hospital, obviously, as many people have mentioned, it's a multi-agency approach, isn't it? And we all have our little sections and parts where we come together, and then equally we have our parts where we're separate. And a big part for us as social workers is then being able to look at the investigation after that point. And if we haven't got the first steps done correctly, such as having medical photographs taken in the most appropriate way and following that procedure, then that lets down the rest of the process for us and potentially means that we haven't obtained the evidence for a child, which could potentially leave them in an unsafe situation. Because I think we all know that actually the legal system is very, very clear about how things are obtained. So that's why we need to make sure it's done correctly. So it wasn't really so much of a criticism, but just more letting everybody know that there is a process and we need to make sure that we follow that.
I think, Gemma, is it that we should encourage constructive criticism, putting an instance, and if I put up an instance, so don't think that I'm criticizing, it's just to make our working better. So I have put instance, I'm not criticizing anyway. I've given examples of brilliant social workers coming with a photograph of the hair straighteners, and at times have occasions, is it when the social worker has not been present, is it, and then have to flag it up with the managers for the social worker to come for assessment, is it, So we are see, is it a good practice and bad practices, but I think, is it the important thing, is it that don't hesitate to challenge, and we should challenge and help to make the system better, the interdisciplinary, interprofessional working better, So thank you. Thanks, Gemma.
Just going on from that as well, what we are looking to do is, because we're currently updating the standards operating policy around child protection medicals, and I think once that's completed and done, we're going to look at putting a learning event on for child protection medicals and what the procedures are. So Gemma, that's really useful that you mentioned that, because what we want to do is make sure that everybody is aware of what the procedures are, so that people do feel comfortable being able to do that professional challenge. So thank you.
Just to add, Michelle Keane. So Michelle Keane's the DS in our MASH, and she's just written, Kellyanne, because I know that you can't see the chat function. From a police perspective, that police are in the same position as social workers, where non-accidental injury cannot be ruled out. We have to rely on background and history as our multi-agency decision making. Detectives work very closely with the social workers in these cases, and we always make sure the children are safeguarded. We have to use our professional judgment in these types of situations.
Okay, thank you. Are there any other questions, Claire, that have come through?
No, I'm not sure if anybody's got their hand up or... No?
No, don't think so. I think those conversations have been really useful, and that's one of the, when we do face-to-face events, we'd be in different groups and we'd be having these really enriched conversations, and it's a little bit more challenging within the virtual world, but it's still it's important. Yeah.
Christine has her hand up.
Okay.
Christine.
Hello. Can you hear me?
Yeah.
Yes. Hi.
Hi.
Hi, I'm Christine, and I'm a court guardian. So I come to this at a totally different perspective from where the medical starts and where the social workers start. And I do hear what the social workers saying about having to make that decision, and perhaps having to make that decision on a solo basis. But I was actually thinking while she was saying that, that's where your management come into being, for you to have some reflective discussion and get their support in terms of how you go forward. But as a children's guardian in the court proceedings, obviously, by the time I'm involved, there's a wealth of information before the court. But that doesn't mean that sometimes I just go solely with that information. Sometimes I have to unpick it all and even get a second opinion on the medical evidence, and that happens quite a lot. Sometimes, as you say, I have to challenge parents and get numerous different explanations from parents. And then, of course, you've also got the court to support you, where the court might decide a fact-finding hearing is required to unpick it all, because the medical evidence might not be complete or inconclusive, or it might not say it was an accidental or non-accidental. And that's where the fact-finding hearing comes in. because it's not just about the injuries, it's about all the other factors, the social, the emotional, all the other factors, because it's very rarely that you'll have a child with an injury and there aren't other factors involved. So there are usually other factors. And I think a very good slide that I saw was the jigsaw, because it's not just one component, or it's not just one person, it's a multitude of components, it's a multitude of issues, it's a multitude of things that you need to take into account. And that's what I wanted to say. It's been very, very useful and very, very informative. Thank you very much.
Thank you for that,
Oh,
Christine.
thank you very much, Christine, for your comments. Yeah.
Thank you. Anything that anybody else wants to say before we draw a close on today's event?
Kellyanne, I was just going to ask, you know, in terms, I know that there were some leaflets that the partnership were producing, you know, around bruising in non-mobile babies. I'm not sure if they have gone out yet, but it may be worth just sending them out after this to the people that have attended. Or
yeah, I mean, everybody, it is attached to the link, that leaflet is, but what I'm going to do is at the end is I will send out the presentation, because there was lots of links on there so that you can access them. So I'll send the PowerPoint presentation out along with the leaflet again. That's what you know, you can print it off, you can pop it up in staff rooms, but it is actually attached to this link if people wanted to access that. Okay.
Perfect, thank you.
Okay, thank you everybody. I'm going to, I don't know whether this will work because obviously my chat function is down, but I'm just going to pop a link in the chat function now. It's saying it's sending, so I don't know whether that will actually come through to you all. But that's the evaluation. We do really value your evaluations. It's not something that we just ask you to do and then we never look at again. It will inform sort of this event. This is something that we want to continue to do in different subject areas, and maybe actually repeat this in the new year with colleagues that weren't able to attend today, because I think the chat function of it's been really useful. So please, if you can click on the link, it probably take you 3-4 minutes to be able to complete it, but it is really useful for us. And if you think of anything else that you'd like to, you know, other events like this that you think would be really useful from a partnership perspective, please pop that in the comments as well, because it does help us. So just to finish, I'd just like to say a big thank you to you all today for being here, and a huge thank you to all our presenters